Would like to welcome everyone to the Health Outcomes Seminar Series. As you know, the seminar series is sponsored by the Center for Pharmacoepidemiology and Economic Research and also our Center for Clinical and Translational Science. Today our speaker is Dr. Marc Atkins, and the title of his presentation is Dissemination and Implementation Science and Ecological Perspective. Dr. Atkins is Professor of Psychiatry and Psychology, also Director of the Institute for Juvenile Research at the University of Illinois at Chicago. He also directs the Dissemination and Implementation Research and Policy Program for UIC CPR. He's a recipient of several grants from the NIH and several private foundations in the areas of childhood ADHD and aggression and community mental health services for children and families living in high-poverty urban communities. His work has established new models for mental health practice in urban communities to address long-standing disparities in mental health care. So please help me welcome Dr. Atkins.
Well, thanks very much. It's a pleasure to be here. I'm thrilled with such a large group. I'm assuming it had nothing to do with the pizza, by the way. I just wanted to know that. But really quick, you just help me out a second here. I just stuck that IJR logo on there. It's brand new. What do you think? Thumbs up, thumbs down. Up? All right, cool, good. I'll let Josh know. Thanks. All right. I'm not a PC guy, so this may not be pretty, but I guess I need to use the keyboard. Yeah? No. This? No.
What should work? The up and down. Let's see. Oh. Let's see.
Oh, yeah, well, what do you think? What do you think?
I think you have to
I haven't done a PC in a long time, and so what just happened? Yeah, that's what I did.
Something.
Got it. Okay, well, let's get going. I have more slides than I should, and so I want to get through some stuff to you. So I'm just going to get right into this here with you guys. So there's four goals I have for this. The first one is I want to give you a little bit of background on what we call DI research, or Dissemination and Implementation Science. I'll give you a little bit of history, slide primer here. And I want to talk to you about what we consider the core research processes that helps us organize our work, because it can, as I'll talk about, it can be fairly confusing. And then I'm going to sort of take the liberty and tell you what we think are some misguided assumptions about dissemination implementation science and the way it's implemented, in particular in regard to children's mental health. If I have a chance, I'll talk to you a little bit about our work and the way that we've implemented it, and I'll give you an example of a recent study. Then I'll end off with new rules, final thoughts, and a favorite quote. So first of all, let me just say it's in medical centers, it's common to talk about conflicts of interest. I don't know of any. Political, yeah, but nothing related to this. However, I want to point out that that's usually thought of as drug studies, and that's very relevant. Hey, Ken. That's very relevant to DI research, as we'll talk about. Conflicts of interest are too common, in my opinion. All right, so let me start off with a little bit of background on translational science and the valleys of death. First of all, as you may know, the newest institute at the NIH is the Institute, the National Center for Advancing Translational Science. We've had one of the translational service awards here, and we're just waiting to hear in the next week that or two that it'll be refunded. 64 centers around the country, and the goal is to bridge the research to practice gap. To give you a little background on this issue of translational science, though, I'd like to just take a step back prior to NIH. This is remarkable that NIH didn't discover this, but I'll do it anyway. Donald Stokes was a political scientist at Princeton, and he was reviewing grants for the National Science Foundation, very frustrated by the common way of describing applied and basic studies on a continuum. One side was basic, the other side was applied, and somehow you put yourself on one side or the other. And he asked a very simple question: where do you put Louis Pasteur? Louis Pasteur, the essentially, if you will, grandfather of microbiology, germ theory. We know about pasteurization. He was among the most prolific basic scientists and applied scientists. And Stokes suggested that we actually do this differently. He suggested that we have a quadrant. And in the, the two axes are quest for fundamental understanding and consideration of use. In the pure basic research, he put Niels Bohr, who developed the structure of the atom and all, and he pointed out that Bohr, as prolific as he was and as great a basic scientist as he was, forever regretted the fact that he didn't stay with the use of the atom as it, of course, developed into the atom bomb. He later developed an institute to try to monitor this, was always regretted that. Stokes points out what would have happened had Bohr stayed more involved in it from the get-go. In the pure applied research quadrant, he puts Thomas Edison, who lit up cities and all, and points out that Edison kept a journal, and he noted the jumping of an electron across gaps. That's not important to me. Later led to solving some big problems in electronics that people got the Nobel Prize for. Once again, perhaps that could have gone quicker. And then, of course, in the quadrant of both, he put Louis Pasteur as a model, especially for publicly funded research. I will say that Stokes did not do the last quadrant, so I just filled that one in. I actually have toyed around with them. You can imagine the various personalities I put in that quadrant, but I tried to be non-political here. So, so translational science is often thought of from this continuum. Discovery, T1, development of tests, evidence-based policy, health systems and prevention, and then public health. This continuum is thought of as the goal of translational science. But many people have talked about this as a valley of death, which is the notion that translational science is where good research goes to die. The idea being that this is very, very hard science. This is not something that's easy to do, to bridge these gaps for a number of reasons. For instance, there's a well-known phenomenon known as the 17-year odyssey, which is the estimation of how long it takes for a research finding to get into practice. Some people have taken the phrase bench to bookcase, noting where the research tends to go. And then, this one I like a lot. Those of us in the field of clinical science in one way or another, this is the Journal of Associated Score of Personal Angst. Are you ambivalent about renewing your journal? Do you feel anger towards prolific authors? Do you ever use journals to help you sleep? Surrounded by piles of periodicals. Do you feel anxious when journals arrive? And this is what I really like. They scored it 0 to 5, and they said if you put a 0, you're a liar. I like that a lot. I think that sums it up well. So there's a lot of angst about this accumulating information and how do we use it, and I'll just point out in the field of children's mental health, it's a very prominent program that's known as Fast Track. It actually is the largest prevention field trial that's ever been funded by the NIH. It's in its 15th year now, 20th year maybe. And the PI, there's a number of PIs, but the main PI is a guy named Ken Dodge, who's at Duke University. And Dodge wrote a paper a number of years ago just pointing out that because Fast Track was an efficacy trial, meaning it was set up to study under ideal conditions what would happen if we deliver a series of interventions. And he pointed out that as he's taken a look at it, Fast Track, these were his numbers, screened about 17.5% of the population of kids they were serving as having at risk for conduct disorder. About half of them got treated. About half of them completed the treatment, and about half of those were successful. So this incredibly expensive NIH trial maybe serves 2% of the population of kids. And he just pointed out there's a problem in the way we're approaching the research. I thought he was a little late to come to it. He did it after he got the money, but I mean, you can't blame him really. But so enter the field of dissemination implementation science. Dissemination, Latin, scattering seeds, the act of spreading something, especially information, wildly. I like that. That fits the mental health field pretty well. To broadcast a message without direct feedback. I note this because I'm setting you up to consider what might be some embedded problems within the field of dissemination. If you think about Spreading something without direct feedback, you might ask yourself how you feel about that. Implementation, the process of putting a decision or plan to effect, moving an idea from concept to reality. It's very top-down, okay? And I'm gonna talk to you a little bit about that. I'm biasing you quite openly here. Russ Glasgow, many of you will be familiar with his work. He's been at the National Cancer Institute for many years. He's now at the University of Colorado Boulder. He probably has, he's probably been one of the most influential figures in the field of dissemination and implementation science, and sort of identified what you might consider to be the broad goals of dissemination implementation science. And he described it as reach, effectiveness, adoption, implementation, maintenance. You can see the point being that we're really not done until we get all of these accomplished. It's not enough just to get something out. We really need to know it's being implemented. We need to know that people are using it. And I will just ask a quick question. How many of you have an Apple Watch? Okay, a couple of very wealthy people in the back have an Apple Watch, right? No, I'm kidding. I'm teasing you. But Apple doesn't care because these are our early adopters back there. We'll get to that in a minute. But the point is that Apple's not stopping with 2 out of what might be 50 people, right? They're going to keep going. So just consider the goals here, and then you can see how complicated this becomes. Now, as it turns out, we really do have a lot of models of DI. I mean, there's really a lot of models of DI. In fact, the last count we came up with 61 of them to choose from and counting. So it's a really very, I would say, confusing field when you're getting into it and you're trying to figure out how do I get started here and all. And so what I want to do is give you a little bit of a tip in terms of how we organize it for ourselves that I think has been helpful for our work. First of all, the backbone of DI was the work of Ev Rogers, who was at the University of Iowa for many years, and came up with the term diffusion of innovation. And this you can see, this is the bell curve that's often used to describe the various categories of adopters, with folks on the left, sorry, this end, whatever then that is, or often called the early adopters or the innovators, the people who buy Apple watches well before anybody knows what they're going to do just because they think they're cool. And then there's the rest of us who are kind of waiting around to figure out if this thing's going to get any cheaper and if it's actually going to be useful, all the way to my wife, the laggards, who are really not interested in anything new or technology-oriented. And we could put ourselves in various categories. The really key point about diffusion of innovation is that there is no right or wrong about this. And one of the things that happens in the field of mental health, I often like to say that, one of the scariest things in the world is a mental health provider with a good idea, because, we tend to then want everybody to accept it. And if you don't accept it, we have all sorts of names for you. We call, sometimes we give you diagnoses, we do all sorts of things to you. But the fact of the matter is that the laggards, when I go into a school and I'm working with teachers, the laggards are my best friends, because the laggards are waiting around to figure out if this thing's going to work. And as much as I might think that I have it all worked out, when I'm working in urban schools, I don't have anything worked out. I've got a couple ideas that may be worth trying, and what I need are some colleagues, often known as teachers, to help me figure out how this is going to work in their setting, right? So those laggards who are waiting around often become our best partners later, right? And I just want to offer that to you. We're going to talk more about that. Let me just do a very quick history. It's probably one of the things I thought about skipping, but I just think it's worth it. Yeah.
Mark, just to qualify about the laggards, is one of the assets about them that they haven't already integrated into practice this new idea, so they're not kind of biased towards how they should do it, or what exactly?
I don't think it's necessarily the bias. What I think they're doing is they're waiting around to see that this works, and that waiting around can be a very thoughtful process. We don't tend to view them that way. We tend to view them as, these people don't like us, or they, they're resistant, or they're, we have all sorts of names for them. But actually, I've learned to go the other way, especially in tough settings. I've learned to say, I respect their hesitancy, and it's up to me to help work that out. And when we start working out those kinks, they start coming on board. many of them. And you might say the late majority, whatever. I don't tend to categorize people that way. It's just this is a conceptual framework.
So among the laggards, it sounds like there's two kinds of laggards. There's some that are thoughtfully contemplating the idea but have decided consciously not to adopt it, and then there's those that are not aware of it at all.
I don't know. I don't know what they're doing. I know that from my perspective as an implementer, they help me out because now I've got to figure out what's getting in their way. Now I'm gonna tell you how we do that in a minute because it's not about, usually it's not about anything I do. So hang on to that and we'll come back to it. But let me just tell you really quickly about this history of diffusion of innovation, because it's kind of an interesting history. Dates well back to the 1930s here. A guy named Bowers was studying ham radio use. First evidence that people who were using ham radios relied on personal feedback from other users, not just mass media. We may take that for granted now, but that's when that first became empirically known. Followed up by Ryan and Gross, very influential study. This was about hybrid corn seed use by farmers. How do you get these farmers to use this new type of seed, which actually they felt was important not to continue the Dust Bowl problem that had happened before. And they found that the farmers were very influenced by exposure to media, but also by their interpersonal ties to model use, which is to say, if somebody else within their network started using a hybrid seed corn, that seemed important. 1943. And then in 1966, probably the definitive diffusion of innovation study or key informant study was Coleman here in Chicago. He's at the University of Chicago. He was studying the use of a new medicine they called gamamine in the study. It was actually tetracycline. And they were trying to determine what would it take for other doctors to use this. And they found that the interpersonal networks led to greater use. Here's a graph of that. There's the chief of staff. This is a social network graph, and you can see all the ties. It's a little complicated, but so who picked up on this right away? This is 1966, right? Who picked up on this right away? Of course, the drug companies picked up on this right away, right? Actually, they did better. They said, I'm not going to just go with the chief of staff. I'm just going to buy them all. Right? I'll just pay them all, and then everybody will start using it, and everything will be good. But I'm just trying to make the point that these aren't necessarily new ideas. They're new to the field of mental health, maybe. They're not new in a lot of other fields, and certainly in cancer, they've been around a long time. The other place where social network theory started getting very prominent, and this is the Framingham study. The Framingham study, as you may know, 5,000 residents followed since 1948. Coming up with the Framingham risk score. How many people here are from cardiology or oncology? I know one. Well, so in those fields, these are very well-known studies, and really pointing out what are many of the predictive factors of heart disease. New England Journal of Medicine published a social network study that I think did more damage to interpersonal relationships than any other empirical finding I know about. What they found in this study, looking at the Framingham heart study, is that if you had a mutual friend who was obese, you were 171% increased risk to be obese yourself, right? So I was just imagining all the dropped friendships that were going on around the country now. It's like, I mean, look at it. I mean, even a same-sex, an opposite-sex friend, a spouse, a sibling, didn't matter if it was a mutual friend. Mutual friend means that I like you and you like me. Well, not anymore. I don't think, anyway. So anyway, but this hit the news, and people started paying attention. In the field of behavioral health, the most prominent study was done by Jeff Kelly, who was then at University of Kentucky, on HIV prevention. Jeff went into gay bars in the South, and he went to the bartender, and he asked the bartender, who is the most popular patron? A bartender would point him out. And he said he would go up to him and say, excuse me, I'm Dr. Kelly from University of Kentucky. Would you like to help me save lives? And what he asked these patrons to do was to endorse same-sex practices. And they would often say, Jeff was a supervisor of mine on internship, they would often say, Doc, I got to tell you the truth, I don't do this myself. And Jeff would say, you don't have to, you just need to endorse it. That's the influence of a key informant. And Jeff then did some studies published in the American Journal of Public Health. That was the first experimental study of key informant intervention in behavioral health, showing that key informants led to other patrons of these bars, gay men, who now were increasing their report of same-sex practices. As it turns out, just so I don't leave you with a misconception that a key informant process is simple, it's actually a two-step process. And this is the work of Ron Burt from the University of Chicago. He's shown that that diffusion information is spread via two processes. And remember now some of those early studies, this is going to go back to that. So direct relationships, information is spread via direct relationships, but adoption and use is spread via structural similarity. And what that means is if you take a look up here on the top, so if our target is circled as target down there, there's a direct relationship between target and A, but not target and B. See that? So information is spread that way. But if you take a look at the bottom, it's actually when B adopts, A is more likely to adopt, and vice versa. When B adopt, target is more likely to adopt, and vice versa. And what he's shown is that, and I'll show you this in a study that we did. This was a study that a postdoc of ours, who's now a faculty member at Michigan State, Jenna Watling-Neal, did with urban teachers. And she was looking at, we had them keep diaries of interventions that they were using, and an intervention study we were doing. And she was able to show that when teacher A, Jenna did this plot for me because, gosh, this gets complicated. When teacher A used an intervention, the target teacher was expected to use it 0.02, reported using it 0.025 times, not very often. And that's a direct tie. But when teacher C used the intervention, the target used it as well. And the point there is that the target and C are both influenced by the same people, but they're not directly tied to each other. So we spread information via who we know, but I won't necessarily use a new intervention. Mike just recommended a new program to me. I'm going to look up that program, but Mike's a really smart guy, so I may not use it until someone kind of like my IQ uses it, and then I'm much more likely to do it. And that's kind of the way someone like me that's not a statistician and doesn't understand those processes and so on. So that's the notion. It's a two-step process, and it's often misunderstood that way. It's not as simple as a key informant telling someone to do something. We also need to see people like them, like us, using it as well. So basically, we describe it as a process, not a program. Key informants are not a program. They're influential peers, not intervention champions. When we go into a setting and we identify who in that setting is most influential with the other teachers there, that person that's identified is not our champion, doesn't even know us. That's not why we're identifying her. We're identifying her because she's influential with her colleagues. We have to earn her respect for our work and her endorsement of our work. So key opinion leaders operate within a highly individualized social influence network, which is to say it usually takes more than one. So the point is that if this group were hanging out together and that group were hanging out together, it isn't necessarily the case that we could identify one person here who would influence that group there. We may need more than one, and we look at the social network ties. Key opinion leaders matter for influence, but peers matter too for adoption. Everybody's important in a social network. And to get back to the point, respect the laggards. They may know more than you think. They're waiting around for a reason, okay? Apple may think I'm stupid. I don't care about that. I'm not using their watch until I have a sense that it's going to help me, all right? And a good company will respect that, and that's what we've been advocating in our field. The second major theme in diffusion in DI research is organizational social processes. This is a close colleague of ours, Charles Glisson at the University of Tennessee. Charles is probably the single person who brought organizational theory into the field of certainly mental health. And what he basically did was point out that organizations are influenced by culture, climate, and work attitudes. I like to talk about Charles Glisson's greatest hits, and essentially I don't have to go into a lot of details because this isn't your area, but essentially he's shown in a series of studies at social service agencies, emergency rooms, child welfare, juvenile justice, that climate and culture really matter in terms of outcomes. The emergency rooms social climate was a very interesting study where he showed that the work teams the degree to which they got along actually impacted the way they interacted with the patients and the families. This was a study that Charles and another colleague, Sonia Schoenwald, published. MST is multisystemic therapy for seriously conduct disorder kids. And Charles was able to show that when his intervention, which he called ARC for availability, responsiveness, and continuity, was combined with MST. So what Charles has done is develop an organizational intervention where he goes into organizations and he works on team climate and gets the administration of the organization to align with what the expectations of the workers and so on. And what he was able to show was that child outcomes improved with seriously conduct disordered kids in those social service agencies that use this organizational intervention. So he's been able to show that organizational climate and culture really matter. They have large influences on practice. Organizations can change. He's shown that too. And this adds another dimension to our understanding of practices. People matter, and the settings in which they work matter. Can't change one without the other. So the next issue is to think a little bit about dissemination implementation science, and as we describe it, disseminating and implementing of what to whom. So this is what we consider a few misguided assumptions. We've published some of this stuff. If you folks are interested, I'm happy to send the article. First of all, the one misguided assumption in mental health is we know what to disseminate. My former colleague in psychology, who's now on a beach in Miami, retired, had a great term for this. He called this faith-based, evidence-based practice. That is to say that we don't know as much about our practices and how they fit within settings as we need to. So the second misguided assumption is that evidence-based practices are appropriate for all communities, and I'll show you a slide that suggests that that's not the case. And the third is that we can overcome the limitations of efficacy trials, Michael, this one's for you, with new tricks, often called statistics, which is to say that efficacy, which is this highly controlled setting, the findings produced under these highly controlled settings, can now be applied in an effectiveness trial where we don't have those highly controlled settings by massaging things. I don't think so. I think that what we're finding is it's not a smooth fit. There's 750 evidence-based mental health treatments for youth by last count. My colleague Bruce Choropita at UCLA talks about all these keys searching for locks. Do we really need all these keys? Are there others we hadn't considered, and who gets to decide? Here's a slide by John Weiss, now at Harvard. John was looking at the backbone of evidence-based practices in kids' mental health, and he asked a question around client, providers, and setting. What is the extent to which those studies were including clients who were actually clients who were going to be receiving mental health treatments in the practice world, the providers who were actually going to be implementing them, and settings? And actually, you can see a significant number didn't report, but essentially the answer is no. They're not the same clients, providers, and settings that we want to be using these things. So it already sets up a problem that we're not representing the population that we need to. This is a slide from David Chambers and Russ Glasgow's recent paper where they talk about the core problem in dissemination implementation science, what they call program drift and voltage drop, which is to say that people aren't using these things the way the developers intended. And when they are being used, we're not getting the same impact, which is just to say that things are not going as well as we might think. So how can we do better? Well, first of all, we're proposing a public health perspective, which is unheard of in the field of mental health. Unfortunately, that's not the case in your field, I hope. And these are models that I suspect you're familiar with. I'd like to talk about the way that H1N1 was addressed internationally. I recognize that I'm probably in a room with people who know more about this than I do, but let me give you my perspective on it. So you recall the H1N1 virus, right? Yes, good. also known as swine flu. And remember that, you know, the first thing that happened is this thing got identified. I'll just go back to this for a second. All over the world, immediately, this amazing crisis, right? And the first thing they do is they isolate the sick. And then, unbelievably, at the CDC and the World Health Organization, they develop a vaccine for this thing within weeks. Incredible. Well, this is the United States of America. And when we develop a vaccine that could save lives, we know what to do. If we have money, we line up at the pharmacy and we buy as many of these as we can. That's the way we do things in the United States of America, but the CDC said not this time. They said, that's not the way this vaccine is going to go out. This is going to go to high-risk populations, pregnant women, infants, people with immune deficiencies, the elderly, and the rest of you go home and we're going to have you do things like learn how to cough into your elbow and wash your hands, and you'll really, this will help a lot. Don't worry about it. Probably didn't, but it made people feel better. And that was the most organized public health and visible public health response I'd ever seen. And I'd like to compare that to the field of mental health, which is exactly the opposite. This is a picture of the cover of the first Surgeon General's report on mental health in 2000, 1999. First ever report on mental health. It was a report on mental health, and within it they were describing kids' mental health as a national priority, systems inadequate. Then we had the new president, the President's New Freedom Commission in 2003, George Bush. Mental health services are fragmented, disconnected, inadequate. Of course, they're much better now, right? No. This is children's unmet need in 13 states. You can see across, you know, in this one regard, you know, we're relatively fair. Even white kids, you know, 60% of them aren't getting the help they need, but of course it gets up to 77% for Hispanic. Other thing, and exactly the opposite of the way a public health model ought to work, the people with the greatest need are the least likely to get mental health services. Not the way we're supposed to be organizing these things, but again, we are the United States of America. If you got money, anyway, I'll stop. And then, you know, this is just a more recent study, and I was trying to fool around with this. I just want to note the two bars on the right. This is community services and school-based services. You can see that the largest bars tend to be even people with kids identified with serious mental health disorders. Almost half of them are likely not to get any services at all. So we still have a major crisis in the 2015 study. Hasn't changed much. This is an older study, the Great Smoky Mountain study, in which this is the study that really first identified that the site of mental health services for the vast majority of kids was schools. Okay? Schools are not structured to deliver mental health services. The reason why schools are delivering what might be called mental health services, but I suspect they don't look anything like we think about mental health services, is because they have to. Because mental health clinics have waiting lists and they could keep people away. Schools can't do that. They have to serve these kids. So these mental health services get embedded in. Not an ideal setting to be delivering mental health services. And so this is just a notion of a continuum is the way we want to do it. And mental health services are often thought of and intensive, possibly targeted, and we're trying to, in our work, trying to see how we can bring mental health services in at the base to have more of a universal focus. So I'll probably just finish with this section and give us a few more minutes. But what we propose, my group and I propose, is that one of the antidotes, if you will, to the problem in the dissemination implementation science field, the fact that we really have not had the impact, that we haven't done the studies we need to do, is to use ecological theory, which I describe as a return to our senses. In the field of mental health, most people know the first person. I don't know if anybody knows who that is here, but that's Yuri Bronfenbrenner. Yuri Bronfenbrenner is well known for having concentric circles and pointing out that kids are nested within families. This is shocking, right? Kids are nested within families, families within communities, communities within country, and so on. And his point there was that behavior was a function of an interacting nature of natural context. And that's how they had their impact on growth and development. The focus doesn't shouldn't be only on kids. The focus needs to be on kids within the settings. In the community psych field, communities are dynamic systems in which individuals adapt behavior to align with goals. Dynamic systems. There's lots of things going on when we go into these settings. And then I just like to note our former president for about 12 seconds, Al Gore, who often talked about, used to anyway before he bought Al Jazeera, but he talked about reciprocal relations among natural elements in an environment. This is the notion of the ecology and the natural ecology and some of the problems that we're running into. These are all elements that we think are important to consider when we think about kids' mental health, sustainability, conserving an ecological balance by avoiding depletion of natural resources. So essentially, when we think about intervention implications of ecological theory, we have a couple of ways that we organize it. Behavior is influenced by multiple levels of an ecological environment. Behavior is understood as adaptive given specific context. Going back to the concept of dissemination and implementation and key informants and so on, if somebody is choosing to do something or choosing not to do something, it's because they view it as adaptive. We can call them all sorts of names because they're not doing it the way we want, but that's not going to get them to do it. And is there anybody here who's in the field of mental health studying? Yeah. So in the field of mental health, this would make more sense to you because we do a lot of name calling. When I develop an intervention on teaching parents how to interact with each other, and I bring it to you and you don't do it, I get really mad about that. You know, because it's like, this is my retirement, folks. You know, I'm trying to make a little money here, so I really need you to start using this intervention. And so the field of mental health is all full of literature on resistance and people who are uninformed. I mean, it's just amazing. So this is why I go around talking about this. I make my mental health colleagues mad at me. But the other thing that we think is a implication for ecological theory is that our job is to enhance local resources and serve community development, meaning that's a notion of sustainability, that the setting that we're working in is going to pick this up and use it for themselves. And so if it's based too much on us and too much on our influence, it's not going to work, which is why when we do our work in kids' mental health, we're not interested in MDs and PhDs and those kind of folks implementing. We want the folks out in the community implementing. They need to own this. So sustainability occurs and the interventions are valued by those within a setting. If it's not valued by them, they won't use it. So the question of fidelity becomes really problematic. Fidelity to what? Fidelity to what I think it ought to be, or fidelity to what they think it ought to be? If we're working together, we can sort that out. And you know, the goal is to redefine effectiveness towards functional outcomes, things that are useful to the settings in which we're working. If we're working in schools, things that schools value, which may not be kids' mental health outcomes. It may be educational outcomes, so we need to be working with that. And so let me skip over. So essentially what we say, and these are our new rules, what we say is, if you're going into a setting that's important to kids, think about what's important about that setting, and that should be your goal. If it's important to kids' mental health, for instance, after-school programs. Eddie in the back there works with us in the Chicago Park District and their after-school programs. What's important about an after-school program for kids' mental health? Well, it's first of all keeping them safe. There's some adult models there. They get a chance to do some peer interactions. So our goals are not for them to implement a mental health intervention that is counseling. Our goal is to help them do a better job supporting kids so that they're interacting more successfully. And then we'll study whether that has mental health consequences. That's our new rule for intervention. We're not asking schools or after-school programs to be mental health centers. We are asking mental health providers to pay more attention to schools and after-school programs because they are important for kids. Ask not what schools can do for mental health. That's my John Kennedy moment. Always think sustainability. And in 5 minutes, I can't do my links to learning, so I'm not. this is our intervention. I just will do this one thing, though. I'm going to show you our service model, and this is how we embed. This was a mental health intervention, community mental health providers implementing this in high-poverty schools with kids with disruptive behavior disorder. And we started with a goal towards increasing academic achievement. These are mental health providers working on this. And we hypothesized that this would result in improved school and home behavior. And the focus on academic achievement was not tutoring. It was things that teachers can do and things that parents can do that empirically are known to improve that. But it isn't, the teachers and parents aren't going to do it because this guy from the university comes out and tells them to do it. They're going to do it because other teachers and other parents who they respect are going to do it. So we integrated that into the model, and this was a new model for mental health practice. And the mental health providers were billing for their service, the consultation they provided to teachers, the direct service to parents, and the support they were providing the kids. And we had data to show that we have significantly more families involved. The L2L stands for links to learning. Close to 80% of the kids the families who started in the project remained in the project, except those who transferred out, because if they transferred out and they weren't in the study anymore. But even 50 or so percent of those. And just to show you, these were observations of classroom behavior, on-task behavior, kids paying attention in the class. And the top graph is our links to learning kids from the fall to spring in the first year. And they went from below 48% to above 55% on-task behavior. And the control group who got mental health services assigned in clinics, you can see decrease, so we had a crossover. And we studied that for 3 years, and on the bottom graph, the PC stands for peer comparison. We got a random sample of peers, and you can see that our links to learning kids across 3 years were approaching peer comparison, so we're pleased about that. And okay, new rules, final thoughts, and a favorite quote, and then I'm going to stop. I have 2 minutes. Programs don't help kids, people help kids. Our goal is to support the people who are most important to kids. Our take on our field of mental health is it rivals NIH in the use of acronyms. That is, people assign their own programs these acronyms. We think it's time to stop the flag waving. Mental health is embedded in experiences. Hospitals and clinics are not. Our job is to keep kids out of the hospitals and clinics and keep them in the natural settings. And big problems need team science. One of my favorite quotes from engineer is, the world has problems and universities have departments, and we need to stop that. We need an expanded mental health workforce. It's not the professionals who are trained, it's the people who are most important to kids, who have the most influence. That's who we consider the mental health workforce. Parents, community members, other people who can support kids. We need to understand what those key predictors are for kids' mental health, keep them out of clinics and hospitals if we can, and help figure out what it is about the natural environment that's going to support them. And that means we're prioritizing settings over programs. It's not important that they implement our program. And we developed our Links to Learning program. It was based on what the teachers were telling us was important, the literature was saying, and then the key opinion leaders were helping us identify. I don't have time to get into that, unfortunately. And we tried to embed some prevention in there. 2 more slides, and then I'm going to stop. Advances in dissemination implementation science acknowledge a new appreciation for the complexity of behavior change and the need for science to serve society. But consideration of the important public health concerns facing our nation suggests a reprioritization of research goals from programs to processes, and a return to a realistic understanding that behavior is best understood in ecological context, that functioning well is what matters most to children's mental health and well-being. And so I just end with a quote, my favorite quote, from Louis Sullivan, who you know was an architect who developed the skyscrapers. And I ask if this might be true for the field of mental health, perhaps your field as well. It is a pervading law of all things organic and inorganic, of all things physical and metaphysical, of all things human and all things superhuman, of all true manifestations of the head, of the heart, of the soul, that the life is recognizable in its expression, that form ever follows function, that is the law. Thank you. And I stop it.